Please welcome moderators Shirag Opadaya and Oren Gottfried.
I want to start with Oren Gottfried, who is faculty at Duke University, a darker shade of blue than where I live, but down the street. And I'll let him get started on how to use QI and quality outcomes.
So I'm going to take everyone through what we've been doing at Duke for quality, and then how to use that quality data with value-based care bundled negotiations. So just first setup is just how we went about getting the data, and then how to use the data. As background, I've been collecting quality value outcome data since 2013. I mostly served our neurosurgery group and our spine group. Our spine group's combined ortho and neuro. We have parallel processes across both. And we have a co-management that helps us with making metrics and going after them for spine. So we have surgeon scorecards I send out to every surgeon every month, outcome-based data, operational data, satisfaction. Recently, we got into outpatient versus surgical center data because many faculty do quite a bit of their practice outside the hospital. We try to trend our data, looking at all metrics per year, year over year, month to month. We try to benchmark compared to top US news centers, regional centers. So I have a very good data engineering team that can pull literally everything. What's nice is they've built us out tableaus, so I can search in real time, anytime, any day. So this is a general setup of one of the tableaus I like. I can keep a tracker on every surgical case, whether it's done at a surgical center, whether it's done at the main institution, outpatient. I can keep track of each surgeon. I can see if it's an urgent case. When you look at data, you have to take out the urgent and emergent when you look at it. So just very briefly, we track things that are common: 30-day readmissions, return to the ED. We track length of stay, average procedure hours. People are getting a pre-op assessment. We look at every return to the OR, look at the reasons. All this data is not just to look at a bunch of graphs. I mean, we actually do case review on every single outcome that's untoward, unplanned. We look at not just DVT rate, PE, but having a hematoma rate as a result of strict DVT prophylaxis. It's very important in any population to trend out the CMI, the risk of mortality, severity of illness. So we're keeping track of the population data and keeping track of how sick they are. Again, looking at mortality, you can't just look at patients that pass away in the hospital. You need to look at outpatient deaths, even up to 90 days. I would argue even further, but as we're going to talk about, value-based care is really 90 days. Early mobilization certainly improves outcomes. So we can break down every surgery by the procedure class and procedure group. You can break it down by payer, break it down by really any outcome you want. If you start looking at surgical data, you can break it down to where all the money is being spent on each of the costs. We like to compare surgeons and look at, the surgeon A that's doing the surgery for, a lower amount of money, but having better outcomes. We look at our satisfaction, inpatient, outpatient. Registries are so valuable, so we incorporate the registry data. This is just NISQIP right here, but obviously QOD, ASR, tracking infections, adherence to antibiotic guidelines, obviously considering social determinants of health. We have an internal registry with 100,000 patients per year with back pain, and we can judge if they're getting guideline concordant care or not. We can track whether people are achieving minimally clinical important differences. So we have good way to optimize care. We use machine learning. So now to the important part, for value-based care, you can ask yourself, are you a high-performing provider? Obviously, we'll all say yes, but we're being judged externally whether we are high-performing. You can see we have to have high-value care, maximize opportunities there. We have to benchmark. You can look on the left, and it shows shared goals: improving efficiency, reducing variability, eliminating unnecessary care. You can see how different companies rate us, with different models, but there's Dr. Red Dot, Dr. Green Dot. Which one are you? We're being judged, we're being followed. You can engage the data by getting into agreements with the insurers, with employers. You can look at this working from left to right. Everybody knows Medicare Advantage is part of our population. It's going to become more and more. But as you go over to the right, there's other models for value-based care that everybody's engaging in. It's probably the most important slide if you're not doing these negotiations. There's retrospective shared saving bundles. And so these are lower risk. They're really no risk. It's just upside, no downside. But then there's prospective, where you're taking risk. You can lose money. It's not just getting money on the back end. But you also have a negotiating power here. And then there's newer models where you're doing direct-to-employer bundling. That's what I see as the future. You can do things based on the surgery episode, or even just based on a condition. So each of the companies or payers or aggregators have different metrics they follow us on. Engage them, because you can start looking at all these metrics. They're everything I showed at the beginning, but just tailored to very specific questions. So these are two different payers, and you can see they care about things that we care about: readmissions, going to a sniff, non-routine discharge, how much we spend beforehand on imaging. So things we follow anyways. This is just an example of a retrospective shared bundle. I took an existing one and made up data. But in general, what you can see is you have a bunch of costs. You can break it down by different sections. It's really this simple, where you might have like 7 columns and that's it. And then you see, are you over or under? Again, this is the retrospective. Really, it's not negotiable. You're following whatever the company wants. And in the end, if you were under enough of the time, you actually get a return. So in this case, 35%. This is that newer model where you can work with aggregators, and they're working at a national level. And you can actually have patient steerage, where you're getting patients to you. Potentially, there's other opportunities. But this is SIC as something for the future. So these are my summary slides. There's all this data being taken on our practices. You might as well engage and see the data. I would say start with retrospective models, because there's no downside. It's an upside model. And as you get good at your data, start taking on the high risk ones, because there's more to benefit, and you potentially can have steerage. So you're getting the patients you wouldn't see otherwise. You may be able to negotiate no prior authorization. You need to know your patients. Like, if you start putting in your patients the high comorbid conditions, deformity, revision surgery, you're going to go over the target. So second to last slide, but in general, many of these models don't account for multi-level surgery. They don't account for deformity. They don't account for revision. So you have to be very select on what patient population you're going to be dealing with. You don't want to throw all your patients in, or you're going to come out above what you should be. So I would say the clinician can engage this process, work together, and I found it to be very fun, and it's been profitable interactions with the companies, and I've been able to use all the stuff I learned through getting the quality data to help the negotiation. Thank you.